So digitorum, think about the digits. It's going to be the second toe to the fifth toe. Next, we have a small muscle called the fibularis tertius. This is a muscle that is considered an extension of the EDL. It's actually kind of part of it. It inserts onto the base of the fifth metatarsal and also plays a role in assisting for dorsiflexion and eversion. It is variably present in population, so not everybody will have this, and it plays a role for foot stability, and clinically, sometimes tenderness along the tendon may mimic avulsional fractions or even tendonitis, usually presenting in pain around the lateral ankle region. The origin comes from the middle part of the anterior surface of the fibula and parts of the interosseous membrane. Insertion goes to the distal phalanx of the great toe. Over here with the extensor hallucis longus. Here is a cheat sheet of the key muscles, their origin, insertion, the proximal and distal attachments, the innervation, along with the key actions. The nerve supply of the anterior compartment. The deep fibular nerve, also known as the peroneal nerve, is a motor and sensory nerve for the anterior region. It runs with the anterior tibial artery, first between the tibialis anterior and the EDL, then between the tibialis anterior and the EHL, and it crosses the ankle to supply the intrinsic muscles of the foot, as well as parts of the first web space. So clinically, when you think about injuries to this nerve, this can cause the famous foot drop, and characterized by inability for dorsiflexion, leading to toe drag during gait, and which patients oftentimes will have to compensate with a higher stepping gait to be able to move the whole leg. So over here, we have a loss of dorsiflexion, and we have this high step gait for compensation, and the foot drop is a distinctive symptom to see. Over here with the fibular nerve. Here is a snapshot of the key anterior compartment nerves of the leg. We have parts of the saphenous nerve that comes from the femoral nerve. Main function is that it travels along with the femoral artery and vein, along with the great saphenous vein to the inner medial side of the foot and ankle. The sural nerve is going to originate from the tibial and common fibular nerves, and it runs between the calf muscles, and it supplies the skin on the back and outer lateral parts of the foot and leg. The tibial is a branch off of the sciatic nerve, runs through the back of the knee and goes to the back muscles of the knee joint. The common fibular nerve, parts of the sciatica, wraps around the neck of the fibula and the fibularis longus, and it supplies the skin on the back of the leg, the knee joint. And then we have the superficial fibular nerve that comes from the common fibular nerve. It runs on the outer leg. It supplies the fibularis longus and brevis, as well as the lower front leg. And of course, the deep fibular nerve that comes from the common fibular nerve, and it runs on the anterior muscles, and then it goes to the front muscles, top of the foot, between the first and second toes, or that web space. The arterial supply of the anterior compartment. The anterior tibial artery, which is a branch of the popliteal artery, supplies this compartment. It passes through the superior interosseous membrane and continues down with the deep fibular nerve. It eventually becomes, at the top of the dorsum of the foot, the dorsal pedis artery. Any kind of entrapment under the tendinous arch of the soleus can actually affect the blood flow, and in some cases it's rare but serious, can lead to ischemic leg pain. Over here you can see the main artery of the anterior tibial artery, and as it goes down it becomes the dorsal pedis artery. Here's a snapshot of some of the key arteries in the anterior compartment of the leg. Popliteal artery, that comes from the femoral artery, and it goes and passes behind the knee, splitting into the anterior posterior tibial arteries. The anterior tibial arteries also form the popliteal, pass through the leg, through the interosseous membrane, and run to the front of the legs. The dorsal pedis artery, which is a continuation of the anterior tibial, runs on top of the foot. Posterior tibial comes from the popliteal, runs down the back of the foot. And the fibula peroneal, which comes from the posterior tibial artery, runs to the back of the leg near the fibula. Now let's take a look at the lateral compartment of the leg. The lateral compartment contains the muscles fibularis longus and fibularis brevis. Both of these are everters of the foot. Their tendons pass behind the lateral malleolus, and they're enclosed in a synovial sheath, this big fluid-filled capsule. These muscles assist with the function of plantar flexion and plays a key role for foot balance, and also when you're walking on uneven surfaces. Their innervation comes from the superficial fibular nerve, and they're very vulnerable to any kind of ankle inversion or sprained ankle injuries. These muscles act on the subtalar and the transverse tarsal joints of the foot, and the innervation here is the superficial fibular nerve. Let's take a look at the muscles closely. Over here is a view showing you the fibularis longus and fibularis brevis. On the right, you have a cadaveric view, and then on the far right, you have the muscles stripped off by themselves. The fibularis longus originates high on the fibula and inserts down to the foot at the first metatarsal and parts of the medial cuneiform. Its main action is to evert the foot, helps maintain the transverse arch, especially during that push-off phase. Clinically, this tendon runs through the cuboid sulcus, and injury to this region can cause midfoot instability and can be oftentimes misdiagnosed as plantar fasciitis in lateral arch pains. So over here you can see maintains the transverse arch, eversion of foot, and the key nerve is the superficial fibular nerve L5, S1, S2. Then we have the fibularis brevis. This is located deep to the fibularis longus, inserts onto the tuberosity of the fifth metatarsal, and it shares a function innervation with the fibularis longus, primarily everting the foot. It's especially vulnerable to avulsions injury during inversion sprain, and is common oftentimes in lateral ankle sprains, where the tendon may pull a piece of the fifth metatarsal away or further up. So origination is from the distal two-third of the fibula, inserts onto tuberosity in the base of the fifth metatarsal, again superficial fibular nerve L5, S1, S2, and then very prone to injury during involsions or any kind of plantar flexion ankle sprains. The superficial fibular nerve is a branch of the common fibular nerve, and it innervates the lateral compartment muscles and continues as the cutaneous nerve. The cutaneous nerve supplies most of the dorsum of the foot, and unlike other compartments, the lateral compartment does not have any direct main arteries. Instead, it receives most of the blood flow from the perforating branches of the anterior tibial artery, and also parts on the inferior side from the fibular artery. So clinically, it's important to know that neuropathy here spares usually the first web space, but causes numbness across the entire dorsum. So any injury to this one will cause the upper part of the foot to have pain, not really the first web space. The gastrocnemius is the calf muscle, and it has a medial lateral head. It originates from femoral condyles and inserts onto the calcaneus venous via the Achilles tendon. It's a strong plantar flexor when the knee is extended and also flexes the knee. Commonly injured in athletes, especially it's part of the triceps surae. And tears here can result in tennis leg injury, oftentimes calf pain and swelling. The origin comes from the posterior surface of the medial femoral condyle, and then the lateral head comes from the lateral surface of the lateral femoral condyle and inserts onto the calcaneal tendon. Tibial nerve S1 to S2. Main function is that it's the strongest, most dominant plantar flexor of the lower leg. Over here you can see the picture of the gastrocnemius lateral head and the medial head, two heads. Then we have the soleus and pentaris. The soleus lies deep to the gastrocnemius and originates from the fibula and tibia. It's crucial for plantar flexion when the knee is flexed and helps maintain upright postures. The pentaris is a small muscle with a long tendon, assists weakly in plantar flexion, and is often harvested and removed for grafting purposes. Injuries to these muscles, particularly in runners, may mimic conditions like DVT, deep vein thrombosis, due to the calf tenderness and swelling. The soleus originates from the posterior head and the upper shaft of the fibula and parts of the soleal line of the tibia, and inserts to the calcaneal tendon, tibial nerve S1 to S2, and the pentaris is really small, but comes from the oblique popliteal ligament, as well as parts of the lateral supracondylar line of the femur, and inserts to parts of the calcaneus. And this one's a really, really weak plantar flexor. Here is a snapshot of the key muscles of that superficial and posterior compartment of the legs. Now let's take a look at the deep posterior compartments of the leg. The deep posterior compartments contains muscles like the popliteus, the flexor digitorum longus FDL, the flexor hallucis longus FHL, and tibialis posterior TP. These muscles function to plantar flex, invert, and support the foot's arches. It's innervated by the key nerve of the tibial nerve and stabilizes the leg and foot during walking. Dysfunction or tightness here can lead to posterior shin pain or even TTS, tarsal tunnel syndrome, where the nerves are compressed deep near the ankle region. The main function is to help support and stabilize the foot and ankle during gait, plantar flexion, and the main innervation comes from the superficial fibular nerve branch. Superficial fibular nerve, the branch of the common fibular nerve. On the right, you can see a cartoon image versus a cadaveric view of these key muscles and their location put together. Now let's take a look at the muscles individually. Popliteus. Popliteus is a small triangular muscle originating from the lateral femoral condyle and inserts onto the posterior tibia. It helps play a role for unlocking the knee by laterally rotating the femur on the tibia side when the foot is planted down. It's deep and hard to isolate clinically, but injuries can also mimic posterior lateral corner instability and also plays a key role in PCL in controlling the femoral rotation. So the origin comes from the lateral femoral condyle and parts of the lateral meniscus, inserts onto the posterior surface of the tibia as well as parts of the soleal line. Innervation is the tibial nerve L4 to S1, and the key action is that it does play a role for unlocking the knee by laterally rotating the femur on the fixed tibia. Here is a visual showing you the popliteus muscle, right here, popliteus tendon right above it. Next, we have the flexor hallucis longus, FHL, which originates from the posterior fibula and inserts onto the distal phalanx of the great toe. It flexes the great toe, assists in the plantar flexion, and is key during the toe-off and gait. Its tendon passes deep to the FDL in the sole and is vulnerable in dancers or sprinters. Oftentimes can result in painful popping sounds under the first metatarsal, and this is what they call the dancer's tendinopathy. So it originates from the inferior two-thirds of the posterior fibula, inserts at the base of the great toe, and its tibial nerve S2 to S3, and it flexes all joints of the great toe. Over here you can see a picture of the FHL, flexor hallucis longus, and to see how it rounds out and comes down to the great toe. Next muscle is the FDL, flexor digitorum longus. FDL arises from the posterior tibia and inserts onto the distal phalanges of digits 2 to 5. Clinically, the FDL dysfunction affects the toe flexion, especially in conditions like pes planus, what we call flat foot, or even claw toe deformations. It should be noted that because it lies superficial to the FHL in the foot, it is realigned by the quadratus plantae. Next, we have the tibialis posterior, TP. Tibialis posterior is a deep, critical muscle for the arch support, inversion, and even plantar flexion. It inserts onto multiple bones, including parts of the navicular, the cuneiforms, and metatarsals 2 to 4. Its tendon passes the posterior to the medial malleolus, making it easy to palpitate. Any kind of dysfunction or ruptures can cause adult-acquired flat foot syndrome, particularly as females age or individuals that are overweight with obesity or diabetes can oftentimes have weakness over here. So this is the tibial nerve L4, L5, inverts and weakly plantar flexes the foot, main supporter of the medial and anterior arch, and dysfunction leads to that flat foot in the adult cases. Over here we have a picture of the tibialis posterior, TP, implicated oftentimes in obese individuals as well as folks that have diabetes. Here is a snapshot of the deep posterior compartment leg muscles, simplified in a chart format, again with the muscles, the key proximal attachments, distal attachments, their innervation, as well as the main action. The nerves of the posterior compartment of the leg, the tibial nerve, the L4 to S3, supplies the entire posterior compartment. It travels with the posterior tibial artery, which lies between the FHL and FDL tendons. It then branches into the medial and lateral plantar nerves to innervate the sole of the foot. It also gives up the sural nerve, which supplies the posterior lateral leg and lateral foot. Any damage here can impair the plantar flexion, affect toe flexion, and result in heel numbness. So you can see how the tibial nerve branches out to the sciatic nerve, comes down to parts of the leg muscle like the biceps femoris, semitendinosus, semimembranosus, adductor magnus, goes down to the gastrocnemius, FDL, plantaris, gastrocnemius, popliteus, soleus, TP, FHL, and all the muscles of the sole, as well as some of the foot muscles at the base. And the common fibular nerve on the right shows it branching out to the tibialis anterior, all the extensor muscles, and the fibularis tertius. The posterior tibial artery is the main branch of the popliteal artery that supplies the posterior leg and foot. It gives rise to the medial and lateral plantar arteries. The fibular arteries, its largest branch, runs within the FHL and supplies the posterior and lateral compartments. Its perforating branches then reaches the dorsum of the foot. There are cases in patients where the peripheral artery disease occurs and there's diminished posterior tibial pulses, and it can be an early sign. It should be noted that the fibular artery is the largest branch of the posterior tibial artery. It supplies these key structures. And then distally, you have the perforating branch that goes down to the dorsum of the foot. So over here you can see as it traces down, the popliteal artery becomes a split into posterior tibial and anterior tibial, and posterior tibial becomes a fibular. The posterior tibial becomes a fibular, and eventually splits down into the plantar arteries, the lateral plantar, medial plantar, plantar arches, the plantar metatarsal, plantar digital, and on top of the foot we have the dorsal pedis, dorsal metatarsal, and the digis ones, as well as the crossing over called the arcuate. So these are the smaller arteries as it progresses off. Let's take a look at some of the clinical applications of the anterior and lateral leg common pathologies. Common pathologies include tibialis anterior strain, often seen in novice runners, which is anterior and lateral leg common pathologies. The common pathologies include tibialis anterior strains, often seen in runners as shin splints. This causes pain in the distal tibia, and this can happen either on the anterior or tibial side, or posterior side. Another one is a common fibular nerve injury. This is due to trauma near the fibular neck, and that can lead to the condition of foot drop. Causes steppage, waddling, or even swing gaits to accommodate. The deep fibular nerve entrapment occurs when there's a tight boots or cast that creates something called a ski boot syndrome, and this results in pain, usually that radiates inside the first web space of the foot. Over here on the right, showing you some of the visuals. The medial tibial stress syndrome, also known as the shin splints, the MTSS. Over here you can see posterior shin splints can occur as well as anterior shin splints can occur. The anatomical foot overview. The foot is divided into the hindfoot, the midfoot, and the forefoot. The key bones include the talus, the calcaneus in the hindfoot, and then the navicular cuboid cuneiforms in the midfoot, and the metatarsals and phalanges inside the forefoot. The surface regions include the dorsum, the heel, and the ball of the foot. Anatomically, the hallux, which is the great toe, and understanding these zones can help you understand pain, deformities, as well as nerve injuries. The digiti minimus is the small toe on the lateral side. Over here you can see the view of the bones in the midfoot, the hindfoot, and the forefoot. The navicular bone is a keystone of the medial longitudinal arch. It articulates with the talus posteriorly, and it cuneiforms on the anterior side. The navicular tuberosity serves as an insertion site for the tibialis posterior, and it's an accessory navicular bone may be present in individuals, about 10 to 14%. This can potentially cause medial foot pain as a result of their foot postures. The cuboid bone is located laterally and forms a sulcus for the fibularis longus tendon. This helps reinforce the second arch called the transverse arch. And then we also have the three cuneiform bones. These ones articulate with the cuboid and helps add to the foot's overall mobility. On the right you can see the view of these bones, the phalanges metatarsals, the navicular and the talus, calcaneus over here. Notice the head of the talus is right here, the neck of the talus is right here, or the cuboid tubercle on the lateral side, tubercle right here on the bottom. The tarsal joints of the foot. The TCN, also known as the talocalcinonavicular joint, is critical for inversion and eversion movements. It's supported by the plantar calcinonavicular spring ligament, which maintains the medial arch. The calcinocuboid CC joint is supported by the long plantar ligament, as well as the plantar aponeurosis. This helps provide the lateral side of the foot some stability. Collectively, the mid-tarsal joints, the TCN and the CC, acts as a functional unit and helps you adapt to uneven surfaces during gait. The calcinocuboid ligament is formed by the anterior border of the calcaneus and posterior border of the cuboid, and it's reinforced by several smaller calcinocuboid ligaments. We also have the metatarsal and phalangeal joints of the foot. The tarsal metatarsal joint, also known as the Lisfranc joint, is stabilized by the plantar, the dorsal, and the interosseous ligaments all around, in all three directions. Injury here oftentimes is referred to as a Lisfranc injury. This is usually a result of high-impact trauma, often seen in athletes. The distal intermetatarsal joints are supported by the deep transverse ligaments, while interphalangeal, the IP joints, are functional hinge joints, and they allow only flexion as well as extension. The hallux has only one IP joint, and it is very important for the push-off during gait. Let's take a look at the fascia and compartments of the forefoot. The planta aponeurosis arises from the calcaneus and fans out to the toe, supports that longitudinal arch, and protects underlying structures. The foot has four major compartments: the medial region, the central region, lateral, and dorsal. These then house the muscles and tendons as well as various neurovascular structures, and the compartmental anatomy is crucial for understanding issues like plantar fasciitis,
deep foot infections, and even compartment syndromes that are a result of surgery or injuries. In the medial compartment, we have the muscles of the adductor hallucis and the flexor hallucis brevis, the tendon of the flexor hallucis longus, as well as some of the medial plantar nerves. In the central compartment, we have the FDB, flexor digitorum brevis, the quadratus plantae, the lumbricals, the adductor hallucis, tendons for the FDL, FHL. It contains the lateral plantar nerves. And then we have the lateral compartment, which contains the abductor digiti minimi and the flexor digiti minimi brevis. And the dorsal compartment is where you have the extensor hallucis brevis, extensor digitorum brevis, as well as several smaller nerves. On the right, you can see the color coding showing you the different compartments, from the medial side in blue to the green side in central, orange side on the lateral, and the interosseous kind of at the base region. The muscles of the foot. There are 20 intrinsic muscles of the foot. 14 of them are located on the plantar surface, with 2 of them on the dorsum, and 4 of them interosseous in the intermediate layer. These muscles coordinate the fine motor control for balance, toe movement, arch support. Any dysfunction can contribute to deformities like claw toe, hammer toe, flat foot. And this is shown in patients that have diabetes or even chronic overuse of the foot. Over here you can see a view of the different layers. Layer 1, showing you both the inferior view, layer 1, layer 2, inferior view, layer 3, inferior view, and layer 4, inferior view. Notice that they're layered on top of each other, so it's very hard to look at it unless you know which layer you're referring to. Interior view over here are the bones and the key structures, and also where those muscles insert to. On the bottom, you can see a very clear picture of the key muscles. So in layer 1, we have the abductor digiti minimi, the flexor digitorum brevis, and as well as the abductor hallucis. Layer 2, we have the lumbricals of 1 to 4, flexus hallucis longus tendon, the flexor digitorum longus tendons, and the quadratus plantae. Layer 3, we have the FDM brevis. We also have the adductor hallucis, and we have the flexor hallucis brevis. And layer 4, we have the plantar interossi 1 to 3, as well as the dorsal interossis. The foot's plantar surface is organized into those 4 key layers. The first layer contains the abductor hallucis, the FDB, and the abductor digiti minimi, and they're all revolving around the action of flexion, toe flexion, and abduction. The second layer contains the quadratus plantae, the lumbricals, and the FDL, FHL tendons. Their main function is to help with toe flexion, as well as the MTP-IP joint coordination. Third layer is going to be where you have the flexor hallucis brevis, FHB, adductor hallucis, AH, and the flexor digiti minimi brevis, FDM brevis, and they help support that transverse arch. The fourth layer is going to be the pad and dab, the plantar, which pads, and the dorsal interossi, dabs, which controls the toes abduction. So the plantar is for adduction, and then the dorsal interossi is for abduction. Just remember the mnemonic pad and dab. Notice that the adductor toe muscles are unipendent in structure, and then the abductor muscles for the toes are bipendent, so they're feather-like shaped. On the right, you can see the visual of how those fibers look. It is very clustered, but let's take a look at the orientation of the fibers. Here is a snapshot of the key muscles of the foot. The first layer, as well as second layer, the name of the muscles, the proximal attachments, the distal attachments, and the key innervation. Notice that the innervation are overlapping. L5S1, medial plantar nerve, L5S1, medial plantar nerve. Abductor digiti minimi comes from the lateral plantar nerve S1 and S3. Quadratus plantae nerve for quadratus plantae. And the lumbricals are going to be a mixture of the medial plantar nerve and the lateral plantar. Then we have the third and fourth layers, the flexor hallucis brevis, FHB, also the medial plantar nerve, and then the adductor hallucis, which is a deep branch of the lateral plantar nerve. Flexor digiti minimi brevis, this is going to be the superficial branch of the plantar nerve, and then the plantar interossi, the pad and dab, dorsi interossi, these are going to be the S1 to S3. Now let's take a look at the nerves of the foot, the cutaneous and the motor innervation. The first innervation is rich and segmented. The saphenous nerve, which is going to come from the medial ankle and the first metatarsal. We have the superficial fibular. This is the dorsum of the foot, except for that first web space. The deep fibular, which is going to be the first web space, plus regions of the intrinsic dorsum muscles. And then the tibial nerve branches are the medial and lateral plantar nerves, which we talked about. They serve the sole. The medial nerve covers the medial 3.5 toes, and then the lateral nerve covers the lateral 1.5. The sural nerve is going to go to the lateral foot and the heel, and the calcaneal branches go specifically to that heel skin. Injuries to these regions can lead to paresthesis, burning pain, weakness, as well as entrapment syndromes. Let's be mindful of the key nerves in the muscle. The medial plantar nerve supplies the abductor hallucis, FDB, FHB, and the first lumbrical. The lateral plantar nerve supplies the deep branches of the interossi, the adductor hallucis, lateral lumbricals, as well as parts of the lateral sole. And the defibrillar nerve supplies the extensor hallucis brevis and the extensor digitorum brevis. So on the right, you can see a view showing you where these nerves flow through. The saphenous nerve showing number 1. And then number 2 is the superficial branch of the fibular nerve. Number 3 is the defibrillar nerve right there, smaller region. And then the lateral cutaneous nerve of the foot, the sural nerve, is number 6. When you have the inferior view of the foot, number 4 represents the medial plantar nerve. Saphenous nerve touches a little bit of the medial part of the ankle. And the lateral plantar nerve shown here in green in 5. Lateral cutaneous nerve of the foot is shown in 6. And the calcaneal branch is in number 7. The arteries of the foot. The posterior tibial artery divides into the medial and lateral plantar arteries after passing posterior to the medial malleolus. The lateral plantar arteries form the deep plantar arch, joining the deep plantar branches of the dorsal pedis. The DPA is a continuation of the anterior tibial artery, and it runs over the dorsum of the foot between the EHL and EDL tendons. Its pulse is key for exam point. Any compromise in any of these arteries can lead to ischemia, particularly in, again, diabetic patients. You can see the medial plantar artery supplies the small regions of the great toe and skin and muscle. The lateral plantar artery goes to the deeper parts of the plantar arch, and then we have the smaller branches. They go to the plantar metatarsal, plantar digital arteries, and the perforating branches. On the right, you can see the lateral tarsal artery, the arcuate artery making a curve, the deep plantar artery further down, dorsal pedis artery as an extension of the anterior tibial artery. Then on the plantar side of the foot, we have the medial plantar artery, lateral plantar artery, posterior tibial artery, and deep plantar arch. The venous drainage of the foot. The foot has superficial and deep venous systems. The dorsal venous arch drains into the great saphenous vein medially, and the small saphenous vein goes into the lateral side. These superficial veins are used for venous access and are also times prone to varicosities. The deep veins accompany arteries and are very important for the venous return. So DVTs often start in the calf region, in the calf veins, and they can propagate up. And an awareness is that particularly in immobilized or post-surgical patients, you got to be mindful. So over here you can see the perforating veins, the great saphenous vein over here, the lateral marginal vein of the foot, and then the small saphenous vein. The small saphenous vein goes laterally, and the great saphenous vein goes medially. Medial, this one will be a lateral. The surface anatomy of the leg and foot. The bony landmarks such as tibial tuberosity, the head of the fibula, the medial and lateral malleoli, the calcaneus, and metatarsals are quite easily palpated. The posterior tibial artery pulse is also felt right behind that medial malleolus, and of course the DPA pulse can be felt between the EHL and the EDL tendons. Palpitation of these pulses is essential for vascular exams. Over here on the right you can see kind of a map showing you where you can palpitate for. Number 1, you can palpitate for the extensor hallucis brevis muscle. Number 2, you could palpitate for the fibularis tertius muscle. Number 3 would be the extensor digitorum longus muscles. And number 4, the extensor hallucis longus. Number 5 will be the DPA artery pulse. Number 6, the tibialis anterior. And that's the medial malleolus, part of the bone, and then lateral malleolus. Over here in the bottom right view, you can see the medial versus lateral view. Again, the 4 represents the extensor hallucis longus tendons. Number 7 would be the navicular tuberosity. Number 8 would be the stanculum tali. Number 10 will be the tibialis posterior tendon. Number 9 will be the tibialis anterior tendon. And number 11 will be the head of the first metatarsal. The clinical conditions of the foot. The plantar fasciitis. This is the most common amongst the hindfoot and causes pain for runners. The pain oftentimes is localized at the medial calcaneal tubercle, and it's worse after rest. Inflammation oftentimes occurs at the origin of the plantar aponeurosis around the calcaneus, and the pain is worse typically in the morning or after rest and improves with activity. Some risk factors include obesity, flat feet, tight calves, and overuse. Another one is the extensor digitorum brevis contusion. This is oftentimes mistaken for edema near the lateral malleolus. It causes swelling and hematoma. And we also have medial plantar nerve entrapment, called jogger's foot. This is when there's compression under the abductor hallucis, and creates a burning, numbness, tingling sensation. Other clinical injuries include the common fibular nerve and foot drop. This is oftentimes one of the most often occurred in the lower limb when there's severe fracture of the fibular neck or when it's stretched and the knee joint gets injured or dislocated. This leads to paralysis of the anterior and lateral compartments of the leg, so the dorsiflexors of the ankle and everters of the foot. As a result, you have the sign for foot drop. The compensation include in letter B, waddling gait leaning to the side. We have letter C, the swing out gait in which the long limb is swung out, laterally abducted. And we have D and E, where there's a high stepping gaitage, where there's extra flexion employed at the hip and knee to move the foot. Some of the key points of the foot arches. The medial longitudinal arch is supported by the calcaneus talus navicular, the first cuneiform, and the first metatarsal. The navicular serves as a keystone and serves as a stabilizing element between the proximal and distal sides of the arch. Dysfunction of the navicular or supporting structures can lead to dysfunction of the entire arch. The key muscles here include the tibialis anterior, tibialis posterior, and the flexor hallucis longus, and of course the ligaments like the spring ligament, the long and short plantar ligaments, the deltoid ligament, and the plantar fascia. The windlass effect is a result of extending the toes that then pulls against the plantar fascia. This then exaggerates the arch's curvature. So you can see in letter A, the medial arch heighten when the foot is fully weight-bearing, over here. And then B, where extending the toes causes the plantar fascia to tighten, resulting in an increase in the height of the arch. Over here, it's 6 centimeters versus the 4 centimeters. Here are some visuals of general foot classifications. Flat arch is called pes planus. The neutral feet is where it's normal, and the pes cavus is when there's a high arch. So either flat arch or high arch. In the pes planus, there's a medial bulge that must be present at the talonavicular joint, and then for a pes cavus, the medial bulge is not present. Over here. The last clinical application is TTS, tarsal tunnel syndrome. This is an entrapment of the posterior tibial nerve or its branches, and the tarsal tunnel is bordered by the tibia, the talus, the calcaneus. This is caused by trauma, tarsal fractures, dislocation, extreme hyperplantar flexion or reversions, and overuse can cause this to occur. The Tinel sign is where you can stroke the medial malleolus along the nerve path, and as a result, any kind of dorsiflexion eversion produces the same symptoms of pain.